Welcome to today's webinar. We appreciate you spending some of your valuable time with us tonight to hear Dr. Rotenberg's presentation on root coverage techniques. We think it's a great presentation. I think you're really going to enjoy his lecture and kind of his enthusiasm for the soft tissue grafting approaches that he takes here. My name is Blake Baucom. I'm the Director of Sales for Osteogenics. And before we get started, I want to address how we'll be interacting today. So we can't hear or see you, but we would love to hear from you. So on the right-hand side of your screen, you'll see a question and answer button. Please feel free to submit any questions that you have along the way with Dr. Rotenberg's presentation. Then towards the end of the presentation, for the last 10 minutes or so, we will address those questions and give him a chance to answer the questions for you. Let me introduce Dr. Rotenberg. Dr. Sean Rotenberg received his dental degree from the Medical College of Georgia and achieves his certificate in periodontics and a Master's of Science degree from The Ohio State University, where he also served as chief resident. Dr. Rotenberg is an associate professor of the Division of Periodontology at the Ohio State University College of Dentistry in Columbus, Ohio. He also maintains a private practice in the Columbus area that focuses on periodontal therapy, implant therapy, and periodontal plastic surgery. Dr. Rotenberg serves as a staff periodontist for Nationwide Children's Hospital. He is also a diplomat of the American Board of Periodontology and has co-authored/authored several peer-reviewed articles in journals such as JPerio and iJomi. Dr. Rotenberg's current research interests include soft tissue augmentation and peri-implant disease, and he has presented at both national and international professional meetings. Dr. Rotenberg, I'm really looking forward to hearing the presentation tonight. I know that a lot of our customers are asking questions about this, and so this is kind of top of mind for many of them. So I'm really looking forward to it. I know they are as well. We appreciate you joining us tonight. Thank you.
Oh, thanks, Blake. So first off, hello to everybody, and thank you for joining us after a long day of work. I'm assuming everyone was working today. I promise there's going to be very few words on the presentations today, on the slides, and lots of pictures, because at the end of the day, you don't want to read, you just want to see pictures. So that's what we're going to do today. I'm also really happy to have this opportunity to discuss this new product, this microsurface allograft, because I've been getting a lot of questions on it. I get a lot of questions via email. I get a lot of questions via Instagram. I get text messages. I get WhatsApp questions. And Osteogenics has done a really good job of marketing the product, and my name, some of my cases have been shown. So I'm the go-to guy right now for questions. So I'm here to answer all your questions at the end as well. And hopefully I can answer a lot of the questions during the presentation today. But yeah, today we're going to talk about using this new microsurface allograft product for root coverage procedures. Little background disclosures. I work mainly in private practice. I do teach at the Ohio State University College of Dentistry. And I also teach at Nationwide Children's Hospital here in Columbus, Ohio. Osteogenics, they invited me to speak today. I do speak for them. They do pay me when I do speak, but I definitely have not given up my day job yet. So I enjoy speaking. I also enjoy speaking on really good topics and about good products. So let's start off with, this is a question that I got when I first started in practice. And I sometimes like to start off my presentations on soft tissue on this. And the first question I once ever got in practice from a possible referring dentist. I was straight out of residency. We go out to lunch. The guy sits down in front of me, really nice guy, and he says to me, "Well, Sean, I might send you some patients, but I got a really important question for you. Do you tunnel?" And I was just kind of taken aback by this question. And, to me, it just showed that, really the person I was talking to didn't get it. But I still have gotten this question. And, I know out there I get questions. Do I pinhole? Do I tunnel? Do I vista? And it's a really weird question. And let me get into why. In perio, we have so many, as periodontists, everyone who went to dental school knows, the periodontists, we're so anal. Everything is about papers. We can't go to the bathroom without telling you which technique we use to pee. So, in as a periodontist, we have all these papers, all these different techniques on how to do root coverage procedures. And really, there's not, there's not one perfect way to do everything. And we're very, very lucky that we have all these different techniques that we can pull from to kind of master periodontal plastic surgery. On top of that, we have all these materials too. We have autogenous tissue, we have allograft tissue, we have xenograft tissue. And really, we can put them all together to create the most ideal result. So when the person I met with when I first got out of practice or into practice asked me, "Do I tunnel?" That was like asking a chef, "Well, do you bake?" Well, yeah, I bake, but again, as a periodontist, we have different graft options, we have different techniques options, and I don't want to be an everyday chef. I want to be a Michelin star chef. So of course I'm gonna know how to grill, how to sous vide, how to bake, how to cook in a cast iron. I'm going to know how to cook steak. I'm going to know how to cook chicken. I'm going to know how to cook fish, because I don't want to follow a recipe. I want to have my own mastery. And again, as a periodontist, I'm so lucky that there's so much literature out there that I can pull from these different recipes that other people have put together to master my technique. Ultimately, though, we do have literature and research to show what the best, what materials and what techniques do give us the best outcomes, the most predictable outcomes. When it comes to periodontal plastic surgery, we know that the subepithelial connective tissue graft is the gold standard. It's unrefutable. Anyone that does soft tissue grafting knows if you want the best results, use a connective tissue graft. And why is that? Well, you get great root coverage. You could also increase keratinized tissue, and you get an ideal aesthetic result that lasts a long, long, long time. So, when a patient comes in with a mucogingival deformity, with lack of attached gingiva, lack of keratinized tissue, root recession or gingival recession, by using a connective tissue graft and leaving it exposed, not only are you able to achieve root coverage, but you're also able to gain keratinized tissue and create the most ideal result. So why do we use allografts? Well, allografts were initially developed in medicine to treat burn victims. Dr. Harris back in 1998 used it for the first time to treat gingival recession, and used it because there are patients where either there's limited tissue on the palate, or there's patients that just don't want the morbidity associated with harvesting soft tissue from the palate. Now, this tissue, because it's donor tissue, it has to be processed so there's no cells, no DNA. Really, it's just acts as a collagen matrix. But research ever since 1998, when Harris first used it, shows us that allograft tissue, this acellular dermal matrix, really can do a good job. There's the meta-analysis done by Hamley Wang's group in Michigan that have since kind of dispersed to Harvard and other schools. I, as being an Ohio State alum, it's hard for me to say that Michigan. I have a hard time giving credit to Michigan, but I will tell you, Michigan has a wonderful periodontal program that puts out excellent research and has great clinicians there. But this meta-analysis really did show that when you compare connective tissue grafts and acellular dermal matrices, both of them show increases in root coverage, increases in gingival thickness, and even an increase in keratinized tissue for acellular dermal matrix. Now, ultimately, like previous studies have showed, the connective tissue graft is still the gold standard. No matter what, I always tell my patients, if you want the best result, we have to use your own tissue. And that's tried and true. But there are times where an acellular dermal matrix, an allograft, really comes in handy. So why do we use it? Where are the advantages? Well, you do get a good outcome. You do get a good aesthetic outcome. Now, is it a great aesthetic outcome? It's not as good as your own tissue. It's not as good as a connective tissue graft, but you still get a good aesthetic outcome. And what I tell patients is I say, listen, we could use your own tissue. We could use donor tissue. Your own tissue is going to give you an A. Donor tissue has pros and cons, it'll give you like a B plus. Now, sometimes that B plus is worth it. Why? Because we don't have a donor site. We don't have to go to your palate. On top of that, we can treat a large number of teeth at the same time without that morbidity of going to the palate, which patients really like. And this is why patients sometimes seek out an allograft. They already know they've heard horror stories from their friends who have had free gingival grafts done. And, oh, my friend had it done. He said it was the worst experience of his life. His palate hurt for months. I don't want it that way. And they're actively seeking an allograft to really reduce the morbidity and have a better patient experience. So, with an allograft, here's a traditional case where I'm using a smooth surface allograft. Here's a patient with mucogingival defects from 3 to 6, from the first molar to the canine, where we have a fair amount of root exposure that's been treated with class 5 restorations, not the most ideal way to treat recession. I had the dentist remove the class 5 restorations. We used an allograft to treat these areas using a coronally advanced tunnel procedure. My graft sutured. With allograft, you have to keep it completely covered. We all know that, because if it's not covered, some of it can necrose with traditional smooth surface allograft. And lo and behold, we have a decent result. Now, if we're going to nitpick, because we had to coronally advance everything so much, we didn't really gain a lot of keratinized tissue. On top of that, we all we did was coronally advance the mucogingival junction coronally, which can sometimes affect the aesthetics. But in this situation, we did increase tissue thickness and we did achieve root coverage. So again, here, because it was such a greater span of teeth to treat, weighing the pros and cons, the patient opted for an allograft rather than going to the palate, where if we had gone to the palate, maybe we would have had to go to both sides of the palate, or maybe we wouldn't be able to treat all the teeth in one session. So allograft does have disadvantages. Like I just showed, that graft, you have to cover it 100%. If you don't cover it 100%, you will either lose the graft or that graft will necrose. So because you're covering the graft 100%, you get limited gains in keratinized tissue, because any coronal advancement you do, and just all it does is brings down that alveolar mucosa, and that also causes the migration of the mucogingival junction. You can also get more significant post-op complications, which we'll talk about. Allografts will typically take a little bit longer to heal. This is a matrix that's devoid of cells. Now, while we're limiting any morbidity to the palate, it takes longer for our body to invade that area and have our own cells infiltrate that matrix until it becomes us. Also, when we look at the long-term studies, again, done by Harris, we show that we see less long-term stability in comparison to autogenous tissue. But the biggest reason, I think, that people avoid using an allograft is the fear of the morbidity that's associated with complications. As we know, when allograft goes bad, it goes bad. Here's a case that I did many years ago where we did a full arch of allograft. And when the patient came back at the 2-week post-op, this is how he looked. This sent pits in my. This gave me a pit in my stomach. This was awful. There's no coming back from this. When an autogenous graft fails, sometimes you can come back from it. Sometimes some of it will take. But when an allograft fails, it's kind of an all or nothing. And not only does it fail, it smells, it tastes bad, it's painful. And there's really nothing you can do at this point except for just to remove that entire allograft and pray that you can still save this case. But with that being said, again, allografts will do well. Here's a case, we already have enough keratinized tissue. So all we're doing is we're coronally advancing over an allograft that I had placed. And lo and behold, we have a nice result with, an increase or gains in root coverage. So when I'm having a conversation with a patient of using autogenous tissue versus allografts, we're kind of going back and forth. I never want to demand a patient do one thing or another. Now, there's certain areas where I recommend autogenous over allograft, or I recommend allograft over autogenous. But there's times too where patients come in and they not demand, but they say, really, I don't want to go through anything unless it's with an allograft, because again, they fear that the harvest site from the palate. We also talk about morbidity and versus the long-term outcome. Also, if Mrs. Smith comes in and she says, listen, I don't want you taking any tissue from my palate, I'm going to talk to them. I'm going to talk to Mrs. Smith. I'm going to say, listen, Mrs. Smith, if we use allograft, again, it will work, but there's a chance that maybe 10, 15, 20 years out, we might have to come back and touch up a couple areas. We talk about post-op complications that, traditionally I would tell people that, hey, if you're getting an allograft and something happens, if something fails, you're going to have a more severe post-op complication than if it was autogenous tissue. We also used to talk about, the smell that might occur or the bad taste. And then also there's technique sensitivity. I've had, residents, first or second year residents come to me and say, listen, Dr. Rotenberg, I really want to use an allograft for this case. And I say, I know you want to, but your skill level just isn't there yet. Because you have to cover that graft 100%, you have to be really good at manipulating the tissue and being gentle with the tissue to be able to passively coronally advance it over that allograft to cover it 100%. So it is more technique sensitive when you're using an allograft versus autogenous tissue. So with all this in mind, and allograft being around since 1998, which is, if you think back to 1998, that's when the first iMac came out. That's when the first, the newest, Apple computer came out. Nothing's really happened over the past 25 years. Allografts, there have been more allografts that come onto the market, but most of these allografts, any changes have really focused on storage, on becoming hydrated or not hydrated, and also if they're prepared with antibiotics or not. But really, there's been, from 1998 up until the last AAP meeting in Austin, there's been no release of a novel allograft product that's really going to increase results and decrease potential complications. So here comes Microderm, which is a microsurfaced acellular dermal matrix. So we're not, this isn't reinventing the wheel. It's taking an allograft, but there's a patented microsurfacing process that increases the surface area of the allograft. So when you look at the allograft under scanning electron microscopy, you can see the microcuts increase the surface area, you can see all the little, pits and fissures in the surface area there that cells are allowed to kind of migrate into. The question now is, well, Sean, does that make any difference? And there actually have been studies, and they're still ongoing, on microsurfaced acellular dermal matrix that show that we do see an improvement in healing. This study comes from the medical literature, just like where allograft first started with burn victims. Here they took 20 patients with equal burns. 10 of the patients received control allografts, traditional smooth surface allografts, and 10 patients received microsurfaced allografts. And then they examined these grafts histologically between 12 and 19 days with biopsies. And when we look under the scanning electron microscope at the same magnification at a microsurfaced acellular dermal matrix versus traditional smooth surface allograft, you can see the difference. You can see how the microsurfaced allograft has more porosity to it compared to the traditional smooth surface allograft, where cells are much more compressed. So what did that translate to in the study? Well, when they did the histology, they found that the microsurface grafts did have a greater cell concentration. So yes, lo and behold, more cells were able to invade that allograft when you compared it to the traditional smooth surface allograft. On top of that, you saw greater thickness. So you saw less shrinkage of the allograft over the initial post-op time period that they had. They also saw more incorporation of the microsurfaced allograft into the existing tissue. The most interesting thing I noticed when I looked at this study was that they found more neutrophils in the microsurfaced grafts, that neutrophils were the most predominant cell that invaded the space. Why that's interesting is that neutrophils are typically, in natural healing, the first cells that invade a wound. So in my mind, the neutrophil, the microsurfaced allograft was mimicking natural wound healing more than when you compared it to the smooth surface allograft. So with this increased surface area, we have more cell infiltration, we potentially have more vascularization, better incorporation, which can lead to better healing. So when you look at microderm, microderm is like a sponge, where traditional allograft, when it comes dry, you typically have to leave it in saline for, 10, 20 minutes before it really sucks up, any liquid that you've left it in. With microderm, the minute you touch any sort of fluid to the material, it sucks it up right away. So, again, this isn't, it's not like all of a sudden we're introducing allograft to the world. This is just reinventing the wheel. We're just making it better. So, one way to compare it is you can compare, where originally we had smooth surface implants, and we thought, oh, okay, if we roughen the implant surface, we increase the surface area, it could lead to better healing, and lo and behold, that did. So again, it's not creating a brand new implant. It's just modifying on the successes that have already been established. PTFE did the same thing. EPTFE, expanded polytetrafluorourethane, for years was the go-to for any sort of regeneration, be that periodontal regeneration or guided bone regeneration. And EPTFE worked really, really well. If you did not have EPTFE get exposed, you would get fantastic bone. But the problem is, if it got exposed, you were toast. So what happens? Well, DPTFE comes in. So again, it's still the same material, but it's packed in denser, so it doesn't have as much surface area, which means that bacteria really won't stick to it as well. And you can find with DPTFE, with the dense polytetrafluorourethane, you can leave these membranes exposed and still get adequate bone regeneration. So again, it's not inventing a new product; it's just modifying and improving on the successes of something that's already been established. So a good material in combination with good technique really can give us wonderful successes. And over the past 15, 20 years, we've really seen huge improvements and these wonderful techniques come out when it comes to periodontal plastic surgery. Be it a pouch, a tunnel, the pinhole technique, the Vista technique, where really we're able to manipulate soft tissue, manipulate the recipient site as atraumatically as possible, improving aesthetics, improving blood flow to the graft material, and giving us a better patient experience. So, the vestibular access techniques that are out there, these are published techniques. But again, this is nothing that's relatively new. There's a lot of periodontists and oral surgeons that were using vestibular access techniques to do grafts for a long time. This is a case I did back in my residency, circa 2008, 2009, where I was grafting around an implant that had a mucogingival defect. So I didn't want to disrupt the papilla, so I made a vestibular access incision to be able to insert my graft. And here's my vestibular access incision. I tunneled my graft through. I used horizontal tension sutures to pull the graft through, and sutured, and lo and behold, we were able to get a nice result, and a nice long-term result. So, why is a vestibular access incision so helpful? Well, first off, it's very easy to be able to put your graft through that incision than it is to tuck it through a sulcus or through a papilla. You can typically place a much larger graft into that vestibular access incision than you can if you're just trying to shove everything through a sulcus. Any periodontist here who's done a pouch technique, knows that trying to shove a soft tissue graft through that pouch sometimes be cumbersome. And especially when you want a good size graft, you really don't want to be trimming your graft just so that you can insert it into a pouch or into the recipient site. On top of that, you can also use that vestibular access incision to manipulate your graft once you're placing it. I do this routinely. Even if I'm not inserting my graft through the vestibular access incision, I'm sometimes using an instrument to kind of place the material exactly where I want it to be that allograft tissue or autogenous tissue. Lastly, you can prepare a full quadrant through a vestibular access incision really within minutes. Where before, if I was tunneling, doing the traditional tunnel where everything is done through the sulcus, to tunnel an entire arch or even a quadrant, I'd be doing it for a long time because I'd be very careful. I don't want to tear the gingival margins. I don't want to do anything to the papilla. But honestly, nowadays, to prepare a recipient site through a vestibular incision, a full quadrant takes no more than 10 minutes. And anyone that's tried this knows it is a much quicker way to prepare the recipient site than trying to go through the sulcus. So what does time matter? Well, time does matter. Anyone that's had a longer procedure that's taken longer than you normally take knows that when that patient comes back, they have more swelling, they have more postoperative discomfort, and it doesn't heal as well. And Dr. Griffin had a great study showing, a wonderful case series on tons of cases where they timed grafts using connective tissue grafts, acellular dermal matrices, free gingival, and they found that you had a really big increase for every minute that went on. For every minute that went on, you saw a 4% increase in moderate to severe pain. On top of that, you saw for every minute that the procedure went on, you saw a 3% increase in swelling. So the longer a procedure is, the more complications that you're gonna incur. And anyone that does surgery, be that periodontoplastic surgery, ridge augmentation, knows the longer a procedure takes you, the more swelling and discomfort that patient will have afterwards. So let's combine this. So we have this novel material, the microsurface acellular dermal matrix, the microderm. We have vestibular access to be able to do this quickly, effectively. So what does that look like in my hands? Well, here's a case where a patient came in with recession on the canine and the first premolar. So here I am using a vestibular incision strictly to help create the recipient site. Okay, so you can see the vestibular access incision that I created up in the mucosa. And I'm using here a very small microperiosteal elevator to create my recipient site. I'm able to very easily go interproximally to elevate under the papilla without severing them. And then once everything's prepared, here I am trimming my microderm. Now I trim my microderm dry, which I do recommend to people because again, as soon as any sort of liquid touches the microderm, it's going to suck up that liquid. And honestly, the first liquid I want this microderm to touch is blood. I don't want to soak it in saline. So here it is inserted into the recipient site that I created. And you can see how filled with blood that microderm is. Now, one consideration, one question people have asked me is, well, once it gets hydrated, can you still suture it? And you can still suture it. It's very easily sutured even once it's hydrated. Typically, I always suture my flaps and my grafts together. So here, I'm suturing with 2 sling sutures, and the patient will come back 2 weeks later, and this is what we look like. And this is really, when people ask me, well, what's the benefit of microderm? This is it. It's the 2-week. It's the 2-week post-op. That is the biggest benefit. When patients come back at 2 weeks using this material, the tissue looks phenomenal. And every case I've done over and over and over, the tissue at 2 weeks looks phenomenal. The patients come back with a lot less pain, less swelling than what I'm normally used to, and the tissue looks incredible. When I compare it to traditional smooth surface allograft, on the left, you can see cases that I did, and these are what the cases look like at 2 weeks. Again, this is not abnormal, and when patients would come back looking like this, I'd say you're healing great. Because I know as time goes on, things will continue to heal and things will still look okay. But at the 2-week mark, when it comes to microderm, I'm seeing a much better soft tissue response than when I'm using other traditional smooth surface allografts. And as time goes on, that continues. So when we look at this case at 6 weeks, you can see, how everything's maturing. The root coverage gains are that we achieved are still there. We go on to 9 weeks and then all the way up to 4 months. We see a really nice result. Again, would I have achieved this 4-month result if I had used a traditional smooth surface allograft? Probably. But again, the patient had an excellent experience and, at 2 weeks didn't come back and tell me this smells bad, this looks bad. Are you sure this is going to heal okay? Throughout the whole time, the patient had an excellent experience. Now, when we compare this to the patient's other side that was treated by someone else using this was actually a connective tissue graft, the patient was thrilled. Yes, it was a connective tissue graft, maybe should have been done with a different technique, but, to be able to give a patient the result on the right, is to me was a huge win. So other cases, here's another case. So 2 premolars, again, mucogingival deformities, lack of attached tissue, gingival recession. Again, you can see my instrument there right by the canine. I'm using a vestibular access incision to create my tunnel. My graft's inserted. Here are my sutures. And again, here's 2 weeks. This is where I love this material. When patients come back at 2 weeks, it looks awesome and the patients are happy. So again, 2 weeks, 6 weeks, here's 9 weeks, and here's 4 months. Okay, so we see there's an increase in tissue thickness. Again, did I take the appropriate camera angles to show you this exactly? Did I do any sort of tissue punches to measure it? No, but you can see it. We had good root coverage. Now, could we have gotten more root coverage with an autogenous graft? Maybe. But again, this still has the limitations that traditional allograft has, except that it just heals a lot quicker. And in my hands, it's healed a lot better. So other ways, that I treat this. So here's, a patient who comes in, aesthetically demanding. Again, I recommended initially to this patient to use her own tissue so that we can do connective tissue grafts. I could leave it exposed. We can gain more keratinized tissue. She didn't want to sit through 2 sessions and she didn't want to go through harvest sites on both sides of the palate. She was, she said, I really would like to do this with an allograft. Okay, then let's do it. So here in this situation, I'm making a vestibular access incision. Typically, when I do cases where I'm treating at the anterior teeth, I'm hiding my incision in the maxillary labial frenum. So here's my vestibular access incision. I'm using, again, a microperiosteal elevator to create my tunnel. I'm continuing I start in the alveolar mucosa and then slowly move coronally until I can get good coronal advancement. Here's my microderm, again, trimming it dry. There's not a specific side for the microderm. And, here it's in 2 pieces. I use a 2x4, split it into 2 pieces. So each were 1x4. And just to show you, here's what as soon as you drop saline on the microderm, it sucks it up right away, just to show, how readily the microderm sucks up any fluid that you place on it. So I'm about to insert my microderm. I'm inserting it through the vestibular access incision. Anyone who's done a VISTA type procedure, very similar. I'm doing more of a modified VISTA. And I'm able to place the graft in one fell swoop all the way through. Once it's in, I can use a perio probe to kind of get the graft exactly where I need it. You can see the microderm through my vestibular access incision. Everything sutured. I placed one piece on covering the central incisor to the canine on the left side, and then one piece to cover the central incisor to the canine on the other side. And then I close up my vestibular access incision with chromic gut. But again, so I send the patient on their way. Again, this is a aesthetically demanding patient who pretty much told me that she wanted allograft. I really had to make this a home run for her. So when she comes back looking like this at 2 weeks, I win. This was a big win for me. And this was a patient who sought me out. She called around and wanted to know, do you use allograft? And, she said, well, it was you or someone else. But I called 7 or 8 different offices. So, this is the patient at 2 weeks. Here's the patient at 4 weeks. So again, could I have gotten a better aesthetic result because I could have increased keratinized tissue with autogenous tissue? I could have, but the patient is super happy looking like this. Another case, very similar case, pre-ortho case. So here's a patient, he's coming in for pre-orthodontic treatment. In this situation, we have to treat all these teeth before he goes into braces. So again, using a vestibular access incision, very similar to the case I just showed you. Here's what he looks like at 2 weeks. Again, this is 2 weeks. This is to me, an incredible response at 2 weeks using an allograft. The patient was extremely happy. Again, at 2 weeks, he already has a very, very nice aesthetic result. And then the patient comes back at 4 weeks. Look, has there been a little shrinkage on tooth number 8 on the right maxillary central incisor? There has, but I bet you that once the patient goes through ortho and that tooth is intruded to some degree, we're really going to see, an incredible aesthetic result when you compare it to the initial photos. Another case, again, I'm showing this case because I was amazed at the 2-week post-op. Here's a case where patient came in, recession from the first molar to the canine, removed the composite class 5 restoration that was on the canine. Again, vestibular access incision, creating the recipient site. Microderm is placed, sutured. This is 2 weeks. Like very little inflammation. We see nice pink firm tissue. To me, if this is what a graft, even an autogenous graft, looked like at 4 weeks, at 6 weeks, I would be thrilled. But this is 2 weeks. As we go out, we do see a little relapse, but a lot of that's mainly because, I didn't do any odontoplasty to these teeth. And the patient did have abrasion / abfraction lesions on the teeth. So here's 4 weeks, here's 8 weeks. And again, when you compare it to the initial photos, that's truly a great success in my eyes. Another case, again, same technique. We have 2 weeks, 4 weeks, 8 weeks. And when in the past, other allografts may have not have been as consistent at the post-ops, over the past year of using microderm, the post-ops are consistent over and over again. This is the tissue response that I see. So I'm going to show you an example of what happens when it gets exposed, because that's another question that I've been asked. What happens when microderm gets exposed? So here's a case I did, again, treating canine to first molar. If you look between the second premolar and the first molar, you can see I made a mistake. Actually, no, it's between the two premolars. You can see I made a mistake. I tied my suture too tight, and I tied it too close to the gingival margin. So what happened? I had the flap necrosis in that spot. And you can actually see the microderm under the flap. Now, if this was a traditional allograft case, I would be sweating bullets. First off, the patient would come in and say, this smells. Why does this smell? Or this tastes bad. And now I'd be telling the patient, you know what? I need you every day to take a Q-tip with chlorhexidine, and I want you to dab it on the site, okay? Every day, dab it on the site, and then I want to see you in a week from now. But this was microderm, and I'd had a lot of good success with it in other cases, and I wanted to see what happened. So I sent the patient on their way. I said, you know what, ma'am, you're healing great. So this is what the patient looked like at 4 weeks. And what do you see? You see the microderm granulating in. So in the past, when I would have had another allograft exposed, I really would have been worried that I would have had, some sort of infection, or the exposure would get worse, or that area would just completely necrose and I'd get no coverage there. In this situation, that exposed microderm is actually granulating in, and you could still see some of that exposed microderm. But when the patient came back at 8 weeks, this is what we were left with. So again, even though I had a small complication, the microderm was forgiving enough where I didn't lose the case. Now, when I look at that premolar, could I have maybe gotten more root coverage over the root if that had never happened? Maybe, but nothing went to total crap, which I was happy with. And the patient was great. No smell, no pain, no swelling, no bad taste. The patient still had a wonderful patient experience. Now, does it work every time? No. Does allograft work every time? No. Here's a case where, again, I treated first molar to canine. But this is what it looked like at 2 weeks. I didn't get the best coverage on the first molar. Did I cover it to some degree? I did. But again, I don't have any necrosed tissue, any exposed tissue. The canine, the 2 premolars, still look great. The patient still had a good experience. They didn't complain of any smell, bad taste, pain, swelling, things like that. So even though this wasn't the best case, when it didn't go 100%, I didn't get the same morbidity that I sometimes get if a case doesn't go great with traditional smooth surface allograft. Not all my cases go perfect, I will tell you that. And here's what it looked like at 8 weeks. Or 4 weeks, sorry. Now, is it only in my hands? No, it's not only in my hands. I have colleagues that have been using it that have been telling me the same results. But here is, this is Dr. Sadia Taslim. She's a first-year resident at Ohio State. Sadia, hopefully you're listening, and but I'm crediting you. But this is a first-year perio resident at Ohio State. She's very skilled, but this is her case. So again, it's not just my hands. It's her case. We're doing it together. She did everything. Okay, she did everything in this case. So here she is making the vestibular access incision, creating her tunnel, inserting her microderm. She did a wonderful job doing it. Getting everything into place. I had her take this photo because what I want to show too is just once that microderm is placed, you can see just the microderm alone and the characteristics of the material and how it does expand once it gets hydrated. It expands about 20%. Look how the material alone is aiding in that coronal advancement. She sutured, did a wonderful job, closed her vestibular access incision. And here we are. Here's 1 week post-op. I normally don't have patients come back at 1 week, so I wanted to show this is what 1 week looks like. And again, patient was thrilled. And here's 2 weeks post-op. The patient previously had a connective tissue graft done by Dr. Taslim, and she did a great job with that. But for the other areas, she's now opted to have an allograft used because she had a very good post-operative experience. So what about long-term? What happens in the long term? Well, this is my wife. So, I don't, I've been only using microderm for about a year now. So I only have a couple cases that are really long-term, but I used microderm on my wife. She had recession on tooth number 5. So we used microderm with a pouch technique, sutured, and this is my wife. I want her to be happy. I don't want her to have any bad experiences. So she comes back. This is what things look like at 2 weeks. She was thrilled. She didn't even take Advil. She was thinking she was going to have to take Advil. She didn't even take Advil. But this is, I was shocked. This is what she looked like at 2 weeks. So I said, okay, let's see how things continue. This is what she looked like at 7 months. And again, Has there been a little shrink back? Yes, there has. Now, does that have something to do with the abfraction lesion that she has in the enamel on the first premolar? Sure, maybe it does. But here's something that's really interesting. Here's the 7-month photo. And next, I'm going to show you the 10-month photo. And the 10-month photo actually looks a little bit better. So again, I actually looked at her mouth yesterday. It's been stable. It's been about a year out at this point. And again, for an allograft, I think this was an excellent result. Again, no morbidity of the palate and good long-term follow-up. Here's the first case I ever did. So here I was treating other teeth, and I had this microderm sample. I think Blake, you might have sent it to me. And I said, well, let me try it. So I placed it around this first molar. I didn't really know which technique I would use. So here it is, sutured. Here's what it looked like at 2 weeks. Again, 2 weeks, with this material and an allograft, I was thrilled with this. So, let's follow this. This is what it looks like at a year. Again, acceptable root coverage, good increase in tissue thickness. Could I have done better if I had done a connective tissue graft and left some of that graft exposed? Probably. But again, for what we were looking to do for this tooth, this was a success. And again, there's stability after a year. So, again, technique has a lot to do with this. You can't just be given this material and expect it to work perfectly. So I'm going to show you a quick video of kind of go over how I use the material. So if you're going to try it, you have some idea of what to do. You can also find this on YouTube. Hopefully, if you put my name in on YouTube, this is the only thing that pops up. So here you can see I've made my vestibular access incision, and I'm starting apically. Obviously, I know where my mental foramen is, so I'm going to stay away from that. But here I am working first in the alveolar mucosa and then working coronally, crossing over the mucogingival junction. Once I've done that, and I really work my elevator interproximally, trying to get as much coronal advancement as possible. Here's the microderm packaging. Here's what things look like. So microderm, when you take it out of the package, it's relatively firm, kind of feels like a thick membrane. I'm measuring the graft here. I kind of eyeballed it. And just to show you, what it's like when we trim, it's much easier to trim dry. You can trim it wet, but with a scissor, it's very easy to trim. Again, just like trimming a membrane. And then, what I wanted to show is kind of what it looks like and how readily it sucks up any fluid. Now, what I haven't tried yet is I haven't tried any sort of growth factor on the microderm, but I would expect that, you could see how readily it sucks up any fluid that you put on there, that a growth factor would be readily absorbed as well. So here I am. Here I was tucking the microderm through a papilla that I elevated. So inserting the microderm into the papilla. I'm not using any sort of tension sutures to pull it through. Once I get it in, part of the way, I'll use that vestibular access incision to move it exactly where I need it to go. And even once it gets hydrated, it is, it's fairly easy to manipulate. I will say, if you hydrate it for too long, it becomes a little bit more difficult to manipulate. Here I'm using my perio probe to get everything into the correct position where I want it. And now I'm suturing using Glycolon. Again, suturing, always suture my flap and my graft dependent of each other. I do not suture my grafts independent of my flaps. The flap is the primary source for blood to the graft. I want them to be sutured together so that if there's any swelling or any movement, they move in unison. So there's my graft stable, and there's the final post-op. And when, again, here's 8 weeks out. So you can see an increase in tissue thickness, great root coverage, and again, happy patient. So over the past 12 months of my hands, Again, I haven't seen any cases with necrosis, smell, infection. My patients have been reporting less pain. I haven't done any pain scales or things like that. Again, this is just my opinion and from what I've been talking to my patients, but less pain, less swelling, and I've definitely seen faster healing. So tips and tricks when it comes to microderm handling. Again, trim it dry. You can hydrate it first, but it's much easier to manipulate when it's dry. It's not side specific. You don't have to worry about the basement membrane side, anything like that. Use whichever side you like. Definitely recommend a tunnel approach, for anything. Now you can do that vestibular access tunnel, which I recommend, or any tunnel approach that you see fit. You always want to insert it dry or slightly wet. Again, comes down to the manipulation and the ease of insertion. And also, I really want blood to be the first thing that microderm comes into contact with. And just like any other allograft, leave minimal graft exposed. So in summary, now, microderm, microsurfaced, acellular dermal matrix, it's another alternative to the connective tissue graft that I can offer to my patients. Does it replace the connective tissue graft? No, but it's an alternative that I can use. It does have this more surface area compared to traditional smooth surface allograft, which from my experience has led to better and faster healing. And I definitely can't wait to see more studies on the material to show these results that I'm seeing in my office. If there's any questions, I'm happy to answer them.
Great presentation. We do have a couple of questions that have come in, and I know we're kind of short here on time, so I'll get into them here pretty quick. I do want to tell the audience there on the right-hand side of your screen is a question and answer button. I think we've already got enough questions. It'll take us the full time, but if you have other questions, go ahead and submit those, and we'll see if we can send those to Dr. Rotenberg via email and get back to you on those as well. But I'll go ahead and jump right in, Dr. Rotenberg. The first question is, can you be more specific on your suturing and what suture you're actually using?
So normally, for me, I use 5-O-glycolon typically, and I'm not just saying that because Osteogenics is on with me right now, but I typically use 5-O-glycolon to suture, the flap and the graft together. I typically do independent slings, so each tooth that I'm treating receives its own sling, where I'm going through the flap, through the graft material, interproximally, around to the lingual, back interproximally, and then through the buccal, flap, graft, around, and then tie. So each tooth typically gets its own sling suture where the flap and the graft are sutured together.
And then this is just a follow-up question that I have. When you're suturing like that, is there worry on blanching of the tissue, creating too much tension in the papilla where maybe there's not enough blood supply? How do you avoid that but make sure you get the right stability?
Yeah, that's that you never want to tie too tight. So definitely as you're doing your throws, making sure that tissue isn't blanching. Again, I'm not saying that glycolon is the must-have for this procedure. If you want to use PTFE sutures, great. If you want to use Vicryl sutures, great. I think to each their own. But I do think that suturing the flap and the graft together is critical and really works well in my hands.
There's a lot of questions here on suturing, and so it makes me think that we need to kind of dive into that a little bit more. So here's another kind of a slight variation on that question, but can you give detail on how to suture these allografts so they're not moving? Do you suture through the graft or just suture the tissue tight to the graft so that it compresses the graft in place?
No, through the graft. We definitely need to do some sort of hands-on. So if I'm inserting the graft through the vestibular incision, I can insert it all the way, and on the most mesial aspect, or where the graft is closest to the vestibular access incision, I can go through the flap, out through the vestibular access incision, grab the corner of my microderm, and then slide the suture back through so that I'm pulling my microderm graft up under the papilla of the most mesial tooth I'm working on. With that, when you position your microderm, anyone that's positioned microderm or any other allograft or even a autogenous graft, you know, you're if the recipient flap is passive, you really are able to lay that in and can do a blind pass of a suture through the flap and through the graft together. Um, there's times where I'll use a perio probe and kind of hold the graft through the sulcus exactly where I want it, or I have my assistant hold it as I pass my suture through. It's definitely challenging. It's not something that you can teach in a minute, but that's how I do it.
Great. Yeah, I think we'll we'll prepare to do some hands-on workshop stuff on this in the future. But another question, and there's a couple of different iterations of it, but it's basically on root surface preparation for
Mm-hmm.
abfraction or erosion of the root surface. What treatment are you doing to help increase or improve tissue attachment?
So I don't do any odontoplasty. The only root surface treatment I do is I root plane the roots. And I'll use tetracycline as a mild etchant on the root surfaces, even though there's studies, Dr. Mariotti had a study saying that really didn't make a difference. I still use tetracycline as a light etchant, on the root surface. I don't know if it makes a difference. It's just when I was taught, that's what I did, and it's worked so far, so I'm still doing it. I don't do odontoplasty because I'm fearful of creating sensitivity, and honestly, I'm just not that great at it. So I don't do it. And in my hands, I haven't found that doing odontoplasty, removing heights of contours, things like that, really makes a huge difference in the long run.
Okay, great. Let's see here. So this is on post-op instructions, and then also your use of antibiotics or corticosteroids. So maybe just talk about those three things there.
Yeah, no steroids. I don't use steroids post-operatively. I do place patients on antibiotics. I'll use either amoxicillin for a week or 3 times a day, 500 milligrams, or a Z-Pak, which I don't love Z-Paks, but they came out and said clindamycin is not the greatest because of risk of C. diff. So, yeah.
And then post-operatively, like what do you tell the patients?
Post-operatively, avoid eating on that side for the first week. After a week, you can switch to something soft, but it has to be mushy, like mac and cheese. No brushing the area for the first 2 weeks. After 2 weeks, you can brush the teeth, but not the gingival margin, and no brushing of the gingival margin for 4 weeks, and no flossing for 4 weeks.
All right, a couple of quick ones here. Do you release the interdental papilla on the lingual or just the facial buccal area?
No, just the facial. I don't do anything on the lingual. Yeah.
Okay,
I'll try to elevate up under that papilla as much as I can. If it's a really thin papilla, I'll be I don't want to tear it, but I'll try to elevate up into that under that papilla as much as I can.
Have you used this for lingual recessions?
I've not used this for lingual recessions. No, for lingual recessions, I still, in the maxilla, I definitely wouldn't, because you can't really coronally advance the tissue on the palate very much at all. And on the lingual, typically the lingual of the incisors, I still would like to use a autogenous graft, because I like leaving the autogenous graft, the connective tissue graft, exposed, so I gain keratinized tissue. Because I think on the lingual, that's really, a big benefit is to actually gain keratinized tissue on the lingual and not coronally advance everything, so that graft is completely covered.
All right, last question here, and this one's pretty interesting. We'll see your reaction here, but have you reflected a flap, sutured microderm to the flap, and then sutured the flap back in place? Very specific technique. Sounds like something's out there. Yeah.
I haven't. That doesn't mean it wouldn't work. I haven't done that. I've never done that with a graft. But again, that's not to say it doesn't work. But again, with an allograft, I'm still trying to do as minimal flap reflection as possible. So to make sure I have as much blood supply to the graft, to the allograft as possible. So I'd be a little concerned doing that because you'd have to kind of do a bigger flap, but it's possible.
All All right, perfect. So I realize there's probably more questions that we're not getting to. If we didn't get your question answered today, we will work with Dr. Rotenberg to get an email response to that and then get the questions out to those that asked them as well, get the answers out, I suppose. So I want to go ahead and wrap it up there, Dr. Rotenberg. We appreciate your time. I know it's a lot to prepare these slides and then also prepare yourself mentally after a long day of surgery. You were mentioning to me earlier how many patients you treated, and I know it's a long day. So we appreciate you spending the extra time with us today to help us educate the audience. I also want to tell everybody we will send out a feedback survey shortly to you via email. Once you fill out that survey and return it to us, then we'll send you your CE certificate. So please be sure to fill out those feedback surveys if you're looking for your CE credit here. And with that, Dr. Rotenberg, we just want to thank you one more time, and we'll tell the audience goodbye. Appreciate it.
Thanks for having me. I appreciate it.
Thanks.